Now we will start the today's CME program, and there are two eminent speakers, Dr. Professor Nand and Dr. Professor Gangadhar. They both are authority in their own work in the DTMS, TMS, and Professor Gangadhar made a ECG machine, and these days he is more involved with the medical education than this clinical practice. So definitely we are going to work towards how to manage the treatment-resistant depression. As a patient with major depressive disorder whose depression does not remit with the 2 or more antidepressant regime at adequate dosage duration in the current episode. So even after giving them the 2 antidepressant for enough duration, they still are not able to alright, and they require the more than this, and this is the kind of a pathway we normally use, that treatment-resistant depression, partial or no response. Now we use augmentation therapies or combination of multiple antidepressants, but ECT and RTMS are the common procedures, and we sometimes use the other medicines like lamotrigine, fluoxamine. And after the remission, then we continue the treatment. Now, of course, these are the procedures which are very commonly used for these kind of treatment-resistant depression, like ECT, ketamine, TMS, deep brain stimulation, and psilocybin is the new one, which is not even available in India these days, but maybe in future we will be using that also. So definitely if we talk about the poor responders and complication of non-responder, the biggest difficulty with the depressive is that suicidal ideation. Then they might require multiple inpatient care, and then of course they are dysfunctional and there is associated medical complications. They sometimes die because of depression. Now, of course, these are the 2 commonly used procedures. One is TMS, another is ECT, and I would like to invite Professor Nand and Professor Gangadhar to come on the dais and update us whatever their experiences are. So, of course, Dr. Nand is in AIIMS and he is a faculty there. He's been we worked together, or he was part of the Tulasi 20 years back, and he started after MD his career in Tulasi, so there is a lot of affection and love we got always from Professor Nand. He is doing a lot of work with neuromodulation and neuropsychiatry, and so I would like to invite, come Professor.
Sir, Professor Gangadhar, and I have no conflict of interest for this presentation, but I have a non-conflicting interest that what Sir has mentioned of the Role of MECT. So I was in Tulasi for almost 1 year in 2004, before joining the AIIMS Delhi as a faculty. So after my MD, I joined the job as I said, I joined in Tulasi. So I'm really very glad to see Tulasi doing. And I feel that it's some sort of personal growth for me. So thank you, sir, for inviting me here and giving the opportunity. So we are a little late today. So we are going to talk just about deep TMS and modified disease, not about the entire TMS, and that is the topic. And most likely we have chosen this topic because deep TMS is now being compared with the modified ECT, like neuromodulation in psychiatry. Certainly, it's a very promising sort of trend in psychiatry. But neuromodulation is something not very new. We have been doing it since long time with the ECT. But if you ask me, I was trying to share with sir also, not this time but last time, that whatever we do in neuromodulation, like psychotherapy is also neuromodulation, that modulates your neurons, that modulates the neurocircuitry, that modulates the neuropathway. And sensory modulation, we keep on doing that through various means. So here we are basically moving towards the mechanical neuromodulation. That means the deep TMS ECT, and that's a new technological development that we are facing or we are trying to adapt. So when we talk about neuromodulation and neurorevenue, so there is huge bunch, like it's a precision treatment. It's a precision treatment. It's a integration with the biomarkers like DDLR. It's a treatment that's very, very personalized. So there is huge technological innovation. If you look at the TMS market, business, clinical use, the last 10 years. So TMS got approved for the depression in 2008. And now the TMS, deep TMS, that is approved for depression and OCD, migraine, and certain more is coming in fact. And they have also included the use of TMS in chronic stroke recovery. And the next is coming up most likely the negative symptom of schizophrenia. The effect of high-frequency TMS, that we have seen that, we have some projects on that, and it seems to be promising because negative symptoms has no treatment as such. Medication does not work. So many more encouraged in the past. So what techniques we use? You all know perhaps the TMS and transcranial light current stimulation, vagus nerve stimulation, DBS, that is deep nerve stimulation. Of course, basically the most voltage one, and then the recent one like magnetic seizure therapy, MST. MST, what the people claim that it is going to replace ECT because the cognitive impairment and dysfunction is much less. It is a claim, but no, there is no bit of studies. Some comparisons are there, but still MST is much lower in terms of efficacy than the TMS. Then another thing is transcranial random noise stimulation. So that is also newly emerging therapy. Then micro TMS. Micro TMS is basically developing a small magnetic chip like what Elon Musk has done and introducing that into the neural system from there. It's an invasive, most likely invasive. They have not developed it, but some research is going on. And it is being popularized before it comes to market. So, out of all these neuromodulation techniques, the most commonly used are the modified ECT and the TMS. And both are approved condition for TRD, treatment-resistant depression. So, you all know what happens in MSCT. We have been using MSCT since long time. You know that the electrical stimuli of various intensity, and that we have stimulus strength certain we need for the effective efficacy in the depression, and there should be certain like more than 2.5 fold and to 6 fold that are seizure threshold. That is non-effective. Of course, we need anesthesia. The problem with ACT is that the TMS manufacturers are projecting the anesthesia requirement. So anesthesia is needed, and the bed is needed, and post-discharge system is needed, and complication of anesthesia is there. So that is one of the reasons that TMS is emerging very fast in the treatment of depression. In TMS in depression has been used since last 2008. If you look at the TMS, it has basically two kinds of frequency that commonly we describe and use. One is a high frequency that can stimulate the cortical area, and another is low frequency that can inhibit the cortical area. And we have of course adequate safety data for the TMS. It is safe except for the seizure. But seizure is not that common. In fact, since 2009 we are using TMS, and we have used in more than 1,000 patients. And we have observed only 3 seizures till date. And one seizure was the patient was on the clozapine, 200 mg. Another patient was on clomipramine, so that could be the possibility. And another patient was having the stroke, that was a part of the PhD thesis. So So that patient to the seizure. Otherwise, seizure we have not observed till date. But the reason being because safety issue is very, very important. The safety concern of the TMS, whosoever it is giving the TMS, is very, very important. If you don't properly calculate the motor threshold, you may precipitate seizure because that may lead to hypertension. So various TMS protocol is there, just like the ECT. Like traditional TMS that was approved in 2008, but traditional TMS used to take 37 minutes. So they were not commercially viable, and patient could take much more time to respond. So then they developed express TMS. Now express TMS is it takes 3 minutes, and there were non-inferiority trials. So it is as good as the traditional TMS, but not more than that, not more effective than that. And some researchers say that it is more effective, but usually it is not as good as that. So express TMS is very, very commonly viable. And after that, the TMS business has picked up. Because then you are able to treat at least 20-30 patients per day. But with traditional TMS, you won't be able to treat more than 6-7 patients per day. Then comes the deep TMS. So deep TMS in the sense, it is just like not the precision. Deep TMS means it stimulates the broader area. It's not unlike figure of 8-5. That means it can stimulate not also little different cortex. It can also stimulate medial also. So just like a fluoxetine, unlike a citalopram. So dirtier is a better now because the people say. So we have the multiple protocols. And one more protocol which is segmental stimulation. You can skip this. So what is proposed mechanism of the ECT? We are using ECT since so many decades now, but we are not very sure how the ECT actually works. So these are the multiple hypotheses, like it enhances the neurotransmitter modulation, it also works on neurotrophic factor regulation, plus it also helps the neural network reorganization. We all know the multiple neural networks are there, and network hypotheses are becoming very popular after the introduction of the RDOF by the US NAMS. And then anti-conversion hypothesis. But in this entire hypothesis, it's not possible to establish one single unified mechanism. So same applies for TMS also. We will see to that part. So how does this TMS and deep TMS works? It is something like this. If you try to take a pulse magnetic field in the underlying cortical area, so it stimulates the localized area of the, say for example, DLPFC localized area, and once we stimulate this underlying cortical area, there is some local mechanism, and this local mechanism is it depolarizes the neurons of DLPFC, and that causes local neurotransmitter release. But as I mentioned, it is not simple stimulation of some set of neurons over there, smaller neurons. It can also stimulate the pyramidal neurons deeper, and that goes deeper. So that means TMS action is not only superficial, it goes deeper also. And once it gets depolarized, the deeper neurons of pyramidal cells, that causes the release of neurotransmitter or some action potential changes in the deeper brain structures. And it is presumed that if this gets activated, then there is the activation of deeper brain neurons that exerts secondary effects on the remaining portion of the targeted brain circuit. So there is a THC circuit, so that can also be activated. So there is a stimulation of entire neural pathway that underlies this local area of the stimulation. And there is observed effect on the increased metabolic changes. And once you do the MRI study, you will find that the increased blood flow in the DLPFC and that goes up to the anterior cingulate cortex. And this happens in the traditional TMS. In deep TMS, this effect is much more impact. So, the whole mechanism can be divided like TMS, classical and non-classical. Classical, as we have mentioned, so classical can be the, if the inhibitory stimulus is there, that may lead to LGD, long-term depression of the synaptic junction, or if it is the accessory, that can be the LTP phenomena, long-term potentiation of synaptic junction. So that totally depends upon what kind of stimulus you are giving and what kind of result you are wanting. Now, recently what people have observed, that it is not just electrical field, it is also magnetic field. But magnetic field is very, very difficult to measure. So, people are now coming up with non-classical effect, but this is unproven. The non-classical effect, there is genetic magnetoreception. So, even with a single pulse of TMS, there is a change in expression of CMOS gene. And it has been observed and established also. So, then there is a quantum effect. It's not proven, it's a non-classical. So that simply means that even the two nerve cells, they are not even connected to each other, they are getting entangled as per the quantum theory. And they are getting stimulated. So this is not electrical, this is magnetic impact. So that depends upon the frequency of the vibration of the nerve cells, and these nerve cells are significant in a specially. So this quantum effect is very new in fact. Dr. Gangadhar is a master of this, he can know, he is very well aware about this quantum. But sir, this is not classical, this is not proven. But so what we are considering nowadays is the combined effect is there. That means the magnetic effect plus electrical effect. So now we are proposing that the TMS is much better in terms of efficacy from ECT because of this magnetic effect and safer. So it is well established now that in depression there is some structural brain changes, and that changes we observe in prefrontal cortex, anterior cerebral cortex, hippocampus, amygdala, and in all these areas there is a decrease in volume and decrease in glial cell density in all these areas. And so ECT, when we give ECT, modified ECT, it improves all this, and that is well established. So certainly there is an increase in the volumetric increase in the amygdala, hippocampus, anterior cerebral cortex, insula, lateral temporal cortex, and up to the basal ganglia. And not only this, you can see here that there is a strengthening of connection between the default mode network and the posterior. So ECT is having effect like a TMS also, because in that TMS modulation, that is based on this network theory. So it also recombines the network as we mentioned earlier. To understand the effect of TMS, triple network model is important. We all know that brain has multiple networks. So among this network, these three networks are very, very important. What is the default mode network? Default mode network means when the brain is resting, learning something, doing nothing, but not focusing somewhere. That is default. And in this network, these nodes are involved, like medial frontal cortex, then temporal cortex, hypothalamic areas, hippocampal coordination, posterior cerebral cortex, then inferior parietal lobe. So these nodes form the default mode network. So this network does not is the electrical switch-like network. It is just connecting the brain area to this particular nodes. Another network is the simple identity network. This network is important to take a decision. This is a problem solving, resolving some issues, So this is important network, and this network is constituted by TLPSC. That is mostly what we know we stimulate this area in the ears. So this is a very important component of the central executive network. And then some part of VLSC also, then posterior parietal cortex, then frontal IQ area. And so if you look at the TMS, most of the TMS delivery we do in the VLSC, because this is the important network component of the central executive network that helps in the problem solving and taking a decision. Then salience network. This network is constituted by the insular cortex, IC, then dorsal anterior cerebral cortex, and insular cortex, temporal pole, and amygdala. Now the role of salience network is it becomes small stimuli, not necessarily. So it becomes very hyperactive. So once salience network is more active, that means the person is depressed and they are vulnerable to focus on something that is not necessary and that is not perhaps of any utility. So this connection between this entire three network that leads to the multiple psychiatric conditions. That could be the depression, that could be schizophrenia, PTSD, disorder, anxiety. So that depends on how much one network is involved. So this is very important to read. So if you just look at this, this is default mode network. So what happens here in depression, when the increased activity or increased functional connectivity within this network, the network that what I mentioned, and not only that, there is a dissociation or impairment between the anterior and posterior default mode network. So if this network is hyperactive, the person is more vulnerable to develop depression. And not only that, then this network is hyperactive and this network is also connected like this network. So there is increased functional connectivity between this network and salience network. So that simply means the default mode network is hyperactive. So someone is vulnerable to develop depression or low mood or anxiety. And if this network is hyperactive, and there is an increased functional connectivity between salience network and this network, EMN. So what will happen? There is a negative bias. The small stimuli, minor stimuli is will pick up, and the negative bias is much more in the brain. And that is based on the outcome system classification that those has proposed in the level. So ECT and the TMS, they reorganize this. They try to rectify this network. And if you look at this now, in the connection of this default mode network and the central executive network that take a decision that helps with the problem solving. So there is a decrease of the connectivity. That means in depression, you are not able to take proper decision because functional activity is poor. It is decreased between the DMN and the salience network, CEN, central executive network. So this is one of the hypotheses that I have given intervention in this one. And it has been observed that if you give the TMS, there is a pre-treatment hyperconnectivity within the DMN decreased significantly. And there is also hypoconnectivity within the CNS at baseline to improve our TMS. So multiple research are there. So this network is significantly improved. This is all we know that in ECT we use multiple kinds of response in TMS we use a different kind of coils like double coil coil. This coil it penetrates much deeper impact. and it can also activate the medial frontal cortex, unlike the figure of 8 coil. Then circular coil, then figure 8 coil, and the recently introduced the deep DMS in the H coil. So these coils are very good to stimulate a very small area of the brain, unlike the H coil. In H coil, what happens is it vibrates, it modulates vibratorily larger cortical region, and the intensity is higher on the left side. That means left DLPS is activated more than the right DLPS, but both are being activated. So we have multiple parameters of ECT, same. Similarly, we have multiple parameters in the TMS also. Like high frequency, low frequency, intermittent intervals, continuous intervals. The clock placement is also very important, both in the ECT and the deep DMS coil. The deep DMS is a little more convenient because you don't have to fix the coil with the patient, you don't have to stand there. But as per our experience, the deep DMS coil also, you have to be careful because of positioning of coil, and you may not be able to elicit properly resting motor threshold, and that may be higher or lower, and that affects the EPC. So the good part is that with the same input coil, you can elicit motor threshold also, you can deliver DMS also. So we have all forms of ECT, like low amplitude ECT, intermediate ECT, then MST that I was discussing but is not approved yet, but people are trying very hard to get it approved, and claim it that it will replace the ECT of some time. Then focal electrically administered therapy, that is very seizure is there, but the intense focal stimulation is there. So cognitive state is much less. With DMS, the deep DMS I have been done. Theta stimulation, that means very short stimulation, very short pulses, and it has good peripheral DMS. And planning is very important. It is something like how you use the medication. So some people know there is no concept of DMS resistant now. DMS non-response is there. That means if some person is not responding to TMS, and if I am waiting, if the patient will go to you, you may change the protocol, and the person may respond. Then how do you try that? Frame the TMS. Then TMS acceleration is also new fashion effect. Why? Because the TMS takes longer time, unlike ECT. ECT has the benefit in that you can give the patient in 6 to 8 sessions or maximum 12 sessions. Unlike TMS, it has to go till 15 session, 20 session, or 30 session. So they are trying TMS acceleration. Then the low synchronized TMS that is being developed, not approved. If you compare the TMS and ECT, give TMS and ECT, what happens? It is something like this. Verified ECT, the response rate is 74%, remission 52%, and high frequency TMS, not deep TMS, the response is only 30%. Then low frequency TMS, it is 8%, violent TMS, 4%, deep TMS, response rate is 60%. So that simply means it is closer to the modified ECT, unlike the traditional TMS. But remission rate is 29%, unlike the modified ECT. The remission rate is there 1.2%. So in this comparison, the modified ECT is certainly better than the TMS. Recently, there was a study published, nationalistic studies. What they have done, they have done multidisciplinary trials by including multiple different patients. They have observed that on an average, the response to deep TMS is 18.2%. And they have used multiple protocols, like 1 session, 2 sessions, 3 sessions per day, up to 10 sessions per day. And they found that there is no significant difference in the protocol. All protocols are same. Statistically, there is some difference, but not. And The effect of TMS lasted for also significant amount of time. That was 87% for 30 patients and 92% the effect was maintained for 180 days for 92% patients. So this is the graph for this study. So you can see that if you are giving 2 TMS acceleration, 3 TMS, 5 TMS per day, 10 TMS per day. So the best response is with 2 TMS per day. And then 5 TMS per day. With 10 TMS per day response is not as good as that. So the better to speak to this. So the protocol that people are trying to develop with TMS acceleration that will take time. It is not very safe till date. So there is competitive evidences, active versus sham, VCT also, TMS also, and TWS also. With VCT, you can see certainly the response is much better. And if you look at that, deep TMS is not as good as the VCT also. But with MST, it is closer to the VCT, as good as the modified VCT. So, we were discussing about suicide intervention. People have that impact. And with modified ECG, you can see here, with modified ECG, the response rate in a big number of patients, more than 4,000, it was 65.9% at DRT and 75% in non-DRT. So the responses is quite good here. Then if it is right, if it was tried by one of the options, with the 131 patients, it was observed that the score of suicide decreased to 0 after 3 sessions of the ECG, up to 38%, and it decreases up to 18.9%. So the score is about 0 or less. But if you look at the DTMS, the response is 45.3%. So there is a good difference, 55 and 47. And one of the studies also looked at the suicidal ideation, and in the systemic review, it was observed that TMS more than 10 sessions, they reduce the suicidal ideation. So in combination therapy is good. So if you look at the role of ECT and DTMS in depression, both unipolar and bipolar, with qualified ECT response is already similar, both bipolar and unipolar. Individual bipolar depression, they need fewer sessions with ECT, and the response is faster with qualified ECT. With DMS, the finding is mixed. And one RCT said that response is up to 48% for DMS bipolar depression. We have experience of treating mixed episode bipolar, and their response also better, not responding to medication with low frequency TMS. The session may have to begin for at least 15 to 20 sessions. But just like in adjunct. So, if you look at the frequency and number of interventions, modified ECG and DTMS, a huge difference. For modified ECG, what we do? 2 to 3 times in a week, and number of patients are 6 to 12, not more than that. But with DTMS, 30 sessions usually for duration, and response is 81%. With the increased number of sessions, the response also goes down. Then the effect that is being maintained very with modified ECT, 37.7% patients left within first 6 months, and 51% left by 12 months. So, in 1 year, half of the patients. With TMS, it is more than this. It is basically they sustained the response, but we mostly close to 44% complete impact. So the effect lasts little less than TMS than the modified ECT. So if you look at the maintenance treatment, with modified ECT, there are fewer labs and recurrences than pharmacotherapy, around 6 months and 1 year. With DTMS, the maintenance group also do well. And if they are in one of the studies, if you look at the IDRS score, that did not significantly change at 6 and 12 months. So 12 months they can sustain like that. Non-maintenance, the recurrence was very high. Adverse effect, of course, ECT, we know the longevity effects are there, scientific are there, plus risk of anesthesia and other issues are there. With TMS, except here, so here, and the response to drug predictor that we can also look at, there is something predictor that we can look into for the good response. Like modified ECT is very good for the early comorbid psychotic postpartum depression, solid depression, and more severe depression. The DTMS, with the mixed anxiety and depression, the DTMS is very good impact. One more thing that is important to understand, that TMS and DTMS is good in certain conditions where ECT can't be used and medicine can't be used. For example, depression can also be pregnancy. Depression with the person undergoing IVF. So TMS is very good in that, and we have used that reduction side effect. The competitive cost is low, difficult to say, because DTMS system is in fact expensive, the cost is high, and people have looked into that, and we observed that TMS had a higher patient insurance cost. The patient preferred TMS more. In fact, we see the patient who preferred TMS, not ECT. And reason could be manifold. The cost benefit of ECT was higher as per this study. But this is US study, not in India. India ECT perhaps much cheaper. So I can say that you're using, Dr. Varkunta can say, because you're using both TMS, DTMS and ECT, the cost you don't know. So DTMS cost effectiveness study has not been conducted, and we're waiting for that. Clinical viability and for ECT and DTMS. There's some issue, as you mentioned, serious decline there, anesthesia every day, pain checkup is required, adverse effect mode. Here in the TMS, no. The issue is lack of training. If you are doing TMS, I am doing TMS, the outcome could be different. Because the localization is very important. Precisely, we put the point. Then high cost, plus one of the issues is daily session. A patient who coming to clinic for 30 days, 20 days, is very cumbersome. So that is difficult for the patient. So to conclude, both modified ECT and DTMS are effective strategy for treatment of depression. Modified ECT seems to be more effective. More research is oriented to establish the efficacy of DTMS. And DTMS acceptability is better strategy because of the system. Thank you very much.
Psychiatry and perhaps even clinical psychiatry, doing more of a study work. I thought when Nand Kumar was presenting, I thought it would be a great opportunity to learn what has happened in the recent years. It's true that acceptability of any new treatment is going to be better, and what drives is the objectivity with which we look into the treatment that were available and what we are going to be using or being told to us be used as new treatments. I just want to draw your attention to this particular slide. 37% of people who received ECT relapsed. So close to 63%, that is at 6 months. close to 63% were sustaining whatever improvement they got with ECT. And that happened in 53% of people at 6 months when they received the GT or DMS. One of the comparisons. Again, an edge for ECT. But these small differences of a treatment better than the newer treatment may not be necessarily be the reason why we should or we should not shift to the new one. There are many other benefits like Nand Kumar said, patient preference is also one very important thing. As long as the patient can afford, he has a right to choose whether I want to travel by a Benz car or I want to travel by a Maruti car. So I think we have to respect the patient's sentiments also. And the reasons for choosing treatment A or treatment B as a preference by him would be many other factors. Ease of taking it, fear of some other injection being given, or the stigma in the society, and fear of some other side effects of the brain, etc., etc. So a person may choose treatment X over treatment Y. It is here I think we will all become responsible to educate the student if there are any differences between the two treatments. I am not even saying benefits of A over B or disadvantages of A over B. I think as a ethical role, when a person is given a choice to choose a treatment, we also would be responsible to enlist what are the differences between them, both in terms of benefits and side effects, and also of course costs. So once this system is practiced, ethical practice of any of the brain stimulation methods is perhaps achieved in the process. So I will have to ask you not to pay attention to that particular slide. When Nand Kumar ji was giving that slide, it suddenly occurred to me that this way of presenting would probably be different in terms of what is better or what is not better with respect to one parameter. The second thing which I have found preferences of accepting RTMS or DTMS, one of the treatments which is the non-invasive brain stimulation, vis-a-vis ECT or even drugs for that matter, is particularly so in young women who are planning to conceive. You may want to, like I remember one of the patients when we were about to start the TMS activity, both research and for treatments. This software engineering lady came and said, for treatment of depression which you have prescribed me, I want you to give RTMS. Thanks to Google, she had done a lot of work. I was wondering why she was asking for RTMS. At that time, DTMS was not available at AIIMS. So 2-3 times I probed, she didn't tell me, and the resident came and told me, sir, she is planning a child and she does not want to be exposed to any medicines whatsoever. That was the first time it occurred to me that this could well be on actual strong indication for TMS or DTMS for that matter. vis-a-vis even ECT, we would be giving some medicine. And although ECT is safe in pregnancy, ECT is safe, there is no teratogenicity that has been described. Even if there is a small chance, that's avoided. But I'm sure that these magnetic fields don't have any effect on all these things. That's a different issue, and I'm not going to confuse you with all these things. So much said about exogenous treatments, non-invasive brain stimulation, exogenous treatments, and biological correlates of the exogenous treatment, ECT versus all these newer therapies. There are a host of biological effects which ECT produced, so that means it was doing some effect on the brain, including the brain network connectivity, and of course a host of positron emission tomography studies showing that dopamine, etc. ECD, including the gene changes, BDNF gene changes, which were described with electroconvulsive therapy, both in animal experiments and in human experiments, human studies. Although we don't know which of the biological interventions, biological changes was actually therapeutic role, we don't know yet. Likewise, RTMS, although may not have studied many of those biological, true biological ones, more CNS effects have been studied, which Kumar illustrated very well. Now, there is a place for RTMS, DTMS in treatment depression, treatment depressive disorders. You look at the other way around, like I was going to instill one out of the box approach. All these treatments are exogenous stimulators. Whether it is medicines, of course, are exogenous. Whether VNS, transcutaneous vagus nerve stimulation, transcutaneous direct nerve stimulation, deep brain stimulation, the deep transcranial magnetic stimulation, repetitive transcranial magnetic, all these things, and ECG of course, all these things are exogenous stimuli and they produce benefits therapeutically. Now, can the same brain be activated from within? This is some research that we have done, although it's out of the context now. I'll just make one example and I'll leave it at that. The treatment is yoga in depression or in schizophrenia for that matter. Of course, benefits are there. Clinical trials have been published. Multi-center studies also have been published in schizophrenia. I'm not here to sell the idea of using yoga in this condition. But what I want to point out is even the biological correlates of yoga also have been demonstrated, whether increases in BDNF, reduction in cortisol, increases in oxytocin levels, and of course the brain network connectivity, particularly here with referring to the default mode network, particularly the anterior default mode network have become better in RTMS, DTMS studies. Likewise, schizophrenia patients who received yoga as a treatment, the coherence in the anterior default mode network was significantly better, and this improvement in the coherence was also correlated with the reduction in the negative symptoms. Perhaps not many studies in biological correlates of many of the biological treatments have been able to demonstrate a biological change correlating with the clinical benefit. So much so, I would say that this one treatment with yoga, this correlation was observed. So the correction was in proportion to the therapeutic benefit that it was giving. So when we are talking of all these newer methods, I think we also need to understand, remember, remind ourselves that there have been other treatments prior to this, prior to all these things, which perhaps are now being repurposed for treatment of psychiatric conditions, although yoga was never introduced for the purpose of treating illnesses, but I'm sure we are repurposing it to treatment of these conditions. So, having said these few points, I wish Dr. Gaurav Gupta very best for all his enterprise in making sure the mental health of our people going to get better. I wish you all the best, sir. Thank you very much for coming.
Thank you, sir. Thank you for your kind words. So, if we have any questions, we can ask about the. Is there any questions? Anybody would like to? I would like to invite Dr. Tulasi. He wanted me to give the book to Professor Gangadhar and Professor Nand. Yes.
Thank you, Dr. Gaurav, for asking me to speak here about my book. Um, I'll only take 2 minutes and I'll explain what this book is all about. I'm sorry to keep you, stopping you from having your dinner. So, I'm introducing my book here, and it's called What You Were Never Told, The Journey from Adolescence to Adulthood. I'll tell you why I wrote this book and the factors that contributed to it. So most of us here are doctors, and the reason for writing this book was personal factors, professional factors, and environmental factors. Let me tell you a little bit about myself. I'm a psychiatrist. I work in Gurgaon. I was born in 1970s, child of 1970s, finished my medical college in 2001. Came from a well-to-do family, from a doctor's family. And the personal factors behind this book is I finished my schooling, I finished my MBBS, but I thought I didn't know anything about how to live life. Had studied, did well in my life, but knew nothing. And the first time I heard the word debit, credit, bank account, types of bank account, I was probably 23 or 24, and I felt, how do you live this life? How do you choose career? My parents, when I was 3 or 4, my father was a doctor, and they said, okay, you'll be a doctor. I said, okay, fine, I'll be a doctor. So nothing was actually taught, you just studied. Somebody asks, how many hours should I sleep? I had no idea. I was a good student. I normally cleared all my exams. I cleared AIIMS exam, but my rank was 70. I didn't know whether to be happy or not. 70 is a good rank in all over India, but at 70 you get nothing. I cleared NIMHANS. I went to the interview and I forgot the side effects of Valproate. So I didn't know whether to be happy or sad. So there were so many emotions, but nobody told me or taught me how to manage failures in life, how to tackle exams, how to manage stress. So those were the personal factors that brought me to writing this book. The professional factors were, I've been working in this field for about 20 years, and most of the questions we are asked are very repetitive. And normally all the young families or people with young families come, okay, my child is doing this, my adolescent is doing this, they're watching so much screen, they're having too much coffee, and the young ones will pester us about cannabis is good, cannabis is not bad. So I thought, why not write a book? The environmental factors was, of course, COVID. It's a COVID baby. So here it is. So I thought it's a good place to introduce my book, and it's available online if anybody wants to see. I've got a few books here if anybody wants to have a look at the book. And I thought I'll present my book to Professor Gangadhar and Professor Nand. Thank you.
Thank you, Dr. Vipul, for sharing some thoughts about his journey. So, I would like to invite everyone for the dinner and drinks. We can discuss few questions, if any, over drinks. Thank you. Thank you for joining us.